Harvey Reynolds, my Gibson coming to you live from ACC 2026, something near and dear to my heart, my NOCA. Talk to us, Harmony, about what you found. You use OCT and MRI to shed some light on what's going on in my NOCA.
Yes, we were looking to find causes of a Minoca presentation in people who come in with a clinical syndrome of MI who have no obstructive coronary arteries. And we know from prior work that a lot of this is atherothrombotic in origin, but some of it is mimicking conditions. And we'd like to be able to pick out who has what so that we can go along with the guidelines that suggest that we should be treating according to an underlying diagnosis. But our and other previous studies have shown that it's not so easy to figure out who is going to have a problem in terms of a coronary culprit lesion, who's got a Minoca mimic. And we also know that Minoca is a female predominant disorder. So among MI patients, women are 3 times as likely to have Minoca as men, which would suggest that there may be sex differences of pathogenesis, but we don't know that. So that was what we set out to study with an extension phase of our American Heart Association funded multi-center project. We enrolled 336 patients, men and women, at 28 sites in the US, Canada, and UK. And they had multi-vessel OCT and were to have cardiac MRI within a week. 284 of them came back for their cardiac MRI. Our main finding was that we could find a cause of the Minoca presentation in 79%. And 59% of those had evidence of myocardial infarction. 20% had a Minoca mimicking condition, didn't have MI at all. And 21%, we couldn't find any cause, so that we're calling idiopathic.
So how does that inform how we care for patients at this point?
I had hoped that we would be able to identify who would have a coronary culprit lesion based on clinical findings, who would have a Minoca mimicking condition. There really weren't many clues to figuring that out. The more OCT vessels more vessels we imaged with OCT, the more likely we were to find a culprit lesion. And troponin was a clue to who would have abnormal cardiac MRI, but not reliable enough so that even people in the lowest decile of troponin elevation, the majority had abnormal cardiac MR. So I think the answer becomes that if you have the imaging available in terms of OCT in the cath lab, go ahead and do that at the same sitting once you've diagnosed MI non-obstructive disease. And if you have cardiac MRI easily available, get it as soon as possible with the hope of identifying the problem early. If you don't have OCT available, then you generally should work on the assumption that much of this is atherothrombotic in origin. And if you don't have MRI quickly available, I'm still encouraging people to get their patient to a regional center quickly because we can't pick out who has a mimicking condition without doing the MR. And that's just so important. It completely changes the therapy from multiple drugs after an MI to you didn't have a heart attack and you might not need anything.
Still a little bit of a riddle wrapped in a mystery topped in secret sauce, isn't it? Well, thanks for your hard work trying to figure it all out. We still have work to do on Minoca, and I cheer all your efforts on. Thanks for joining us today.